All right, I can certainly echo the little fish in the big pond, and I really thank you guys for allowing me to be a part of this. I'm looking forward to being a member of CWIS for many years. So I'm going to speak to you today about defining outcomes, and this is the 1,000-foot view of defining outcomes. Very basic definitions of outcomes. We'll talk about consideration in outcome properties. I'll introduce some of the conceptual models of health outcomes. And then lastly, in the end, just learning to evaluate for and address bias, just kind of a beginner's level at doing that. So I think we all understand what an outcome is. An outcome is our endpoint, is our variable that we measure our interventions against. But why do we define them? And really we define them, in my mind, for two reasons. One is to organize our entire study. So if you think about it, you start with your question or your aim. And then you have to decide what outcomes you're looking at, primary and secondary outcomes. And these are directly incorporated into your hypotheses. They influence your design and subsequent analysis. So if you don't define your outcomes, you really don't have an organized study. That's the obvious. The second is if you don't define your outcomes, and I'll try and today, give you a systematic way of trying to define your outcome. If you don't, then you're not able to avoid bias with each of your outcomes. So I think we all understand what primary and secondary outcomes are, but just, to be clear, primary outcomes are really your main study aim or objective, and they're incorporated literally into your primary null or alternative hypotheses. Likewise, secondary are the same thing. They arise from any or align with any secondary study objectives and can literally be incorporated into secondary hypotheses. Now I'll use the CWIS non-flail trial kind of as examples to learn how to categorize and define outcomes, because I think a lot of us are familiar with that. And if you look at CWIS, what do they have as their primary outcome? They looked at the numeric pain score. Secondary outcomes they looked at were narcotic requirements, bedside IS, pleural space complications. You can see the rest there. But I think a word to the wise, when you start defining your primary and secondary outcomes and choosing these outcomes, if you create a mess of more than one primary outcome and many secondary outcomes, you're going to create a very unclear study. Regardless of the outcome that you choose, and we'll learn how to categorize our outcomes in a little bit, but regardless, they all have the same properties that we need to understand. Because when we're defining our outcome, we need to understand these properties to address certain biases related to that outcome. Now they can be reliable. I think we know that that's test retest, that's measured via statistics. They have varying degrees of validity. The content validity is the accuracy with that it measures what it's intended to measure. And construct is really the same. It's just measuring a non-physical attribute. And there's also phase validity, and that's the degree to which the expert perceives that the measure is actually assessing what it's intended to do. There's a lot of variability between different outcomes, and that's the distributions of values across the outcome, and they can be responsive. So responsiveness is usually discussed in the context of our PROs, our patient-reported outcomes, and we'll go over that in a little bit. The two biggest conceptual outcome models that are used are these two here, Wilson, Cleary's, and the ECHO. I'm going to talk about the ECHO model because I think it incorporates three realms and is more comprehensive. So basically, the ECHO model focuses on either clinical, humanistic, or economic outcomes. And all the outcomes we do in health research really fall underneath these three realms. Clinical outcomes are just that. I mean, I think we understand a clinical outcome is a measurable change in health status due to an intervention. They can either be intermediate or final. When you look at the non-flail, they had many clinical outcomes that were their secondary outcomes, narcotic requirements, bedside IS, the pleural space complications, and whatnot. They can be final clinical outcomes, something like mortality. Clinical outcomes tend to be our most objective of outcomes, right? But we need to further define our clinical outcomes to avoid biases. And so they can be an isolated clinical outcome, something like, or something like a composite or intermediate outcome. So a composite is just that. A composite is a series of items, and it's often used when maybe one item itself is rare. So we group them together as a composite to increase our power, to increase the incidence of that outcome being measured. So when you look at pleural space complication, for example, we combine hemothorax and empyema or pleural effusion. Now, there's a downfall to using composite outcomes like that, and that's because there really can be varying definitions, not only across institutions and studies, but even in the same study, I've seen it have varying definitions. So, number one, you have to be careful that it has to be clearly defined. And number two, if the intervention does reduce the occurrence of a composite, so if the rib fixation does reduce the incidence of pleural space complication, we don't know if that's necessarily all of its components or one of its components, so you have to substratify that and identify it. Also, things like intermediate clinical outcomes. These are our surrogate clinical outcomes, and it's a surrogate for the condition of interest, and it's used to reduce the burden of measurement, so or follow-up required. If you think of bedside incentive spirometry, we don't really care about the number. I don't care that it's 1600 or 1800. What I care about is what it's a surrogate for. It's the chest wall function or the patient's pain, and we'll go over that a little bit more. So moving on from clinical outcomes, there's the humanistic outcome realm, and that's the impact of the intervention on our patient-reported outcomes, which we use a lot of in chest wall injury. And these can be generic or specific. And they're questionnaires, they're surveys. When you look at what non-flail used, actually their primary outcome was a numeric pain score. That's a PRO. They also had two secondary outcomes, which were composites of two or more generic scales, which were then modified to be disease specific related to our rib fracture or fractured patients. There are a couple of important other factors in PROs that really need to be defined if you're going to use them, and that's a concept called the minimally clinically important difference. We're going to, later on today, you're going to hear more about patient-reported outcomes, but to introduce the idea, it's the smallest difference that the PRO can detect, and it has to be clinically relevant to the patient. It needs to be clearly defined if you're going to use those. And lastly, the third realm is economic outcomes, and these are the impact of interventions on cost. And there's really three areas: cost identification, benefit, and effectiveness. Cost ID is really just that. You measure the cost of applying the specific treatment to the population, both the direct and indirect costs. Cost benefit is you compare the monetary costs of the intervention against the standard of care, and then any savings that result from that are your cost benefit. Mortality is also assigned a dollar value in a lot of these cost benefit outcomes, and that's of course pretty controversial, as opposed to it is also cost benefit outcome analyses are also controversial in general. And then the last is the cost effectiveness, and that's three items really. You take what you spent, that's your cost identification, and did you show the cost benefit versus the standard of the care? And then did your intervention actually make a difference in your specified outcome? That's your cost effectiveness. So this is kind of the meat of what we're here to talk about. What happens if you don't define your outcome? Well, basically you get a measurement bias, and it's kind of easy to understand. If you have an unclear outcome definition, so if you use a PRO that lacks validity. So let's say that CWIS non-flail didn't change their generic pain scales or quality of life scales, and they made it less valid to our patient population at hand, the chest wall injured patient. Well, then you've decreased your validity there, and you're going to introduce a misclassification area, which is a measurement bias. And that shows equivalency across the treatment group, which is of course going to bias you towards the null. And then you're going to conclude that maybe a smaller or no effect actually exists for your intervention. And PROs have more than just misclassification biases that we need to identify when we're defining them. There's something called acquiescence bias, and that's that patients like to agree with statements in questionnaires just because they like to. So you have to use yes and no type of questions, positive and negative type of questions. There's social desirability biases, and that's the patients often like to cast themselves in the best light. And I think most importantly, when we're using our PROs, is what to do with missing data. because PRO data are not missing at random. If someone's in poor health, they're less likely to complete the assessment. And if the patient dies, obviously you've missed that data capture. So failing for defining what to do with that data is really going to overestimate the health of your populations. So I wanted to take the last couple of minutes to I mean, we've learned about, or you probably already knew about what an outcome is, primary, secondary. You know about these realms, clinical, humanistic, and economic realms. And then we talked about the properties of each of these. But so what does it really look like? I mean, you can imagine, just let's take incentive spirometry. So we decide that we want to look at incentive spirometry as a secondary outcome. I clearly define it. We say that it's the maximal inhalation of the patient using an incentive spirometer. And then we clearly put it in its realm. That is a clinical outcome. And furthermore, it's an intermediate clinical outcome. So we know that we have to make sure that it's valid. I mean, is incentive spirometry a valid measure of chest wall function? We need to make sure it's reliable. If you think of incentive spirometry, we all know that if you give the patient the incentive spirometer and you ask them to do the breath, the first breath's awful. The second one might be better. The third one might be best. So we have to define the validity of the test. We have to define its reliability so that we say that, well, we're going to take the fourth and the best incentive spirometry or whatever, but it has to be clearly defined. Once we understand the properties of each of our outcomes, then we'll be able to reduce any kind of misclassification bias, and we're going to maximally identify the treatment effect if one truly does exist. And I really think the best way to do that is to have a checklist. I'm writing a protocol now, and I have a checklist for each that looks just like this. I mean, for each of my primary and secondary outcomes, I take each of my outcomes, I clearly define them, I put them in their realm. Is it a clinical, economic, or humanistic outcome? And then I choose the properties that I can maximally affect to decrease my bias. I really don't have anything else to teach you all. Thank you very much. Do questions after.